Well, terrific. As you can see, we've got a guest joining us from another part of the country, and it's a perfect tie-in. So let me introduce you to Dr. Larry Epstein. Larry was the president of the American Academy of Sleep Medicine at the time that they received ABMS recognition. So through connections in this group here and all of that, we got put together with Larry and said, hey, it'd be great if you could come tell us some of the good, the bad, the ugly of everything that you've done and accomplished. And so, Larry, we just finished the conversation up to date on where we are with our efforts of getting venous and lymphatic medicine recognized, the ins and outs. I think you heard a couple of those comments and questions there at the end as you signed in. So with that, hopefully you'll be able to hear all the technology works well, and he can see the audience. And so I've got him set up so he does see you guys. So don't make too many faces and all of that. But we'll turn it over and the good, the bad, the ugly, their experiences, and hopefully we'll be able to do some question and answers as we go as well. So.
Thank you, Dean, for the invitation. If you could let me share my screen. Make me a co-host.
That should work. You there?
Yep, we're there. Let me know when you are able to see my slides.
And we do.
All right. Well, thank you for the invitation. Good afternoon, everybody. And it does bring back a little bit of flashback into things that we went through. As Dina said, I'm currently a practicing sleep specialist in the Division of Sleep and Circadian Disorders at Brigham and Women's Hospital in Boston. And I've been very involved with the American Academy of Sleep Medicine and in their leadership, particularly during the time of our recognition of as a medical specialty. And so I've been asked to speak a little bit about how we got there. Some disclosures of potential conflicts. These are groups that I consult to. The one of relevance to this talk is the first one, the American Academy of Sleep Medicine, which is really the reason why you invited me here. And so what I'd like to do today is give you a little bit of history of sleep medicine and its development, the organizations involved in that development, and then how we were able to achieve recognition as a specialty field. So sleep is a relatively new field of medicine. Our recognition by ACGME and ABMS were in the early 2000s. One of the sort of unique features of us is how multidisciplinary we are. We have practitioners from internal medicine, neurology, psychiatry, family medicine, otolaryngology, and anesthesia. So sleep really affects all organ systems and disciplines. And so our members reflect that. The other bit that has brought us to attention is that sleep disorders are really very common. We currently have over 70 described disorders in the International Classification of Sleep Disorders. The NHLBI estimates there are about 50 to 70 million Americans who suffer chronically from disorders of sleep and wakefulness. And these disorders have pretty significant health consequences in terms of other disorders that they contribute to, as well as significant impacts on quality of life and even healthcare costs. So the big question is, how did we get here where we are today? Historically, although sleep has been known by everyone basically forever, it really was in the realm of philosophers and artists for most of our history. In fact, the picture on the right is from Charles Dickens' Pickwick Papers from 1836, in which he described a character, Joe the fat boy, who he said always sleeps, goes on errands, fast asleep, and snores as he waits at table. So it was a really good description of obstructive sleep apnea. And in fact, we take that, the Pickwickian syndrome, which describes obesity hypoventilation, comes from this description. The ability to start looking at sleep as a more scientific entity didn't happen until we were able to start looking at action potentials and what was going on inside the head. The first time that happened was 1875. Richard Catton looked at the brainwave activity of rats, but it still wasn't until 1925 when that technology was turned towards humans, and we saw the first measurement of human brain electrical activity by Hans Berger, basically the start of the EEG. And it was 1937 is when somebody let that recording start to go when people were sleeping. And Alfred Loomis described some of the changes that occurred in the EEG during sleep. But at that point, scientists didn't really want to stay up all night. So they didn't watch somebody all night long, and the early descriptions were only partial descriptions. It wasn't until the 1950s that overnight recording of sleep really happened. In 1953, Azarinsky and Kleitman, the University of Chicago, reported the discovery of a whole new stage of sleep, rapid eye movement sleep. And that's pretty much what you see up in this top polysomnogram. This is an EEG, this is respiratory rate, and all of this, these undulating movements are the eyes going back and forth during sleeping, rapid eye movement sleep. And it wasn't until 1957 that all this was put together, and the first description of the overnight human sleep cycle by Dement and Kleitman. This is a picture of what we call a polysomnogram, which describes this. And this is what you see. Someone takes a while to fall asleep, and they go into non-rapid eye movement sleep, into deeper and deeper stages of that, the more restful part of sleep. And then they cycle between non-REM and rapid eye movement or REM sleep over the course of the night. So rather than being this passive time when nothing happened, we learned that a lot goes on during sleep. Development, growth, surveillance for illness, consolidation of memory. It's a very active state of being, which makes sense for something we spend a third of our life in. And now as the scientists started looking at sleep for the course of the night, we began to recognize things going wrong. And we started to see the pathophysiology of the described sleep disorders. So in 1960, Vogel described the changes we saw in narcolepsy, the dissociation of REM features into different times and different ways. In 1966, Gastaut described the sleep and breathing disorder that became known as obstructive sleep apnea. So all this is relatively recent history. Once we began to recognize that there were problems in sleep, we needed to do something to solve them. So treatment for sleep disorders was initiated. The first sleep disorders center occurred in 1972 at Stanford. William Dement started the Stanford Sleep Clinic. And he and his colleagues proposed a clinical practice model that pretty much is what we still do today, where there is a specially trained sleep specialist who guides the care of patients with sleep disorders. They use overnight sleep studies to evaluate what goes on during sleep and also develop quantitative measurements of excessive daytime sleepiness. Not long after we started looking at sleep, organizations started in order to bring those people together to talk about them. The scientists got together first, and in 1961, formed what was called the Association for the Psychophysiological Study of Sleep, which eventually became the Sleep Research Society. And they focused on the scientific methods for measuring sleep and wakefulness, looking at the neuroanatomy and physiology of sleep, and recognizing the link between circadian biology and physiology and the timing and around sleep. Not that long afterwards, we saw the establishment of an association for clinicians. First established in 1975 as the Association of Sleep Disorders Center, which eventually became what is today the American Academy of Sleep Medicine. The focus of this organization was on representing sleep specialists and sleep centers, to establishing and maintaining the standards for evaluation and treatment of sleep disorders, and promoting to the medical community and the general population at large the role of sleep and sleep-related disorders in clinical medicine. Not too long after they began to organize, they recognized that this was really a distinct information base and disorders that deserved their own recognition as a specialty. And so they laid out a path to recognition for the field. First was to maintain clinical standards, how to take care of patients, how to recognize them. For those people who are doing that on a regular basis to ensure their competency, you need to establish an examination process for specialists. You need to provide forms for the exchange of information, both clinical and research. Establish and review a standard diagnostic classification. So we're all looking for the same things. And then educate and bring in new clinicians as a way to expand the field. And so the organization began working through this path rather successfully. So the first step was establish accreditation standards and a process for achieving sleep center accreditation. And the first, and that was started in 1977. Following that, to keep people abreast of what was expected as part of that, to practice good sleep medicine, began to develop and publish clinical practice guidelines, the first of which came out in 1979 and are continuing to this day. To create an examination process, it created a sleep board, started giving it in 1978, and that became what was called the American Board of Sleep Medicine, which was our method of giving a board before formal recognition. It was considered kind of a rogue board, but it was a way of establishing expertise in the field. In order to provide a way for the scientists and clinicians to communicate with each other, established the first sleep journal called Sleep in 1978. The research and the Sleep Research Society and the American Academy of Sleep Medicine came together and started doing a joint meeting in 1986, which continues, and we're going to have our 50th anniversary in a few years. And in 2005, recognizing that there was more information that needed to be got out on a clinical side in addition to the basic science, in 2005 started the Journal of Clinical Sleep Medicine. Shortly after getting together, the group set the standards for diagnostic classifications, establishing a classification of sleep disorders in 1979. And that nosology has been updated regularly. We're now onto the third edition of the International Classification of Sleep Disorders, which is what everybody refers to in terms of giving a diagnosis to a patient with a set group of symptoms and findings. And to educate clinicians and expand the field, we began to offer fellowship training programs. In 1989 was the first one. These were accredited by the American Academy of Sleep Medicine as we worked towards building a sufficient amount so that we could apply for official recognition. So you can see that the path that was laid out, we've been pretty successful in following that map to success. To show you some information, this is the growth in accredited sleep facilities starting from the beginning. This is through the American Academy of Sleep Medicine. There are other organizations that accredit, particularly JCO. There are two others as well. But you can see a pretty large growth. So there are currently over 2,500 accredited sleep centers nationwide. There are also other sleep facilities that don't go for accreditation. So the number of places doing sleep is larger than this. This is the growth in board certified sleep specialists. So you can see the people entering the field. So this was for the American Board of Sleep Medicine exam, our rogue board. And you can see the large growth in this over time. The big spike in 2005 when people recognized there was going to be a new board coming and they needed to get into this one in order to be able to get into the next one. And this shows just sort of the growth of our fellowship training programs over time. These were typically between 1 and 2 year programs. They were accredited again by the American Academy of Sleep Medicine and became one of the bases for which you could then sit for the exam. So once we had gotten to the point where we thought we had a good amount of evidence that this was a legitimate field and we had an organization and ways of training people in it, we sought specialty recognition from the education and exam organization. So we approached both ACGME, the Accreditation Council for Graduate Medical Education, and the American Board of Medical Specialties, asking to be acknowledged as our own specialty field. We approached both of them. Initially, the ABMS was not interested. They didn't see a reason to do it and said no. But the ACGME was interested, and they actually came out and did a series of site visits at our fellowship programs to see whether there's something legitimate. And looking at the curriculum and how separate it was from what was being done in other specialties, what the quality was of the fellowship programs, ACGME decided they would indeed begin to accredit sleep medicine training programs. Once ACGME was accrediting them, the ABMS said, well, if they're going to be trained, then you have to develop a board for them. And so their decision to admit us into the club came after ACGME had recognized our fellowship programs. And so the fellowships were accredited and started. The first ones were in 2005. And then the first board examination under the American Board of Medical Specialties was in 2007. Because of the multidisciplinary nature of the field, ABMS did not set up just a sleep board. What they did is they created a conjoint board. So there were representatives, it was a sleep board, but it was had representatives from each of the participating other specialties, internal medicine, psychiatry, neurology, pediatrics, otolaryngology, family medicine, otolaryngology, anesthesia. So and when our graduates apply to sit for the board, they actually apply through their home board. So someone who had previously done a pulmonary and critical care training, then did a sleep fellowship, they actually go to the American Board of Internal Medicine to register for the sleep exam. But it's the same sleep exam for all the different specialties. So this shows you our progress. This is the people who have graduated, who have passed the boards. You can see that there's a big spike at the beginning. That's not that there's been a lack of interest in sleep. It's that all those people who previously had the old ABSM board were given 7 years to take the new board. And so that you're seeing all those people coming over. When they originally set up our board, there were three pathways in. There was going through an accredited ACGME fellowship program. There was having the old board from the ABSM, or there was still an experiential pathway in which you could show that if you spent a certain amount of time with a board certified person, you could then sit for the exam. Those alternate two pathways, other than the fellowships, only existed for the first 3 exam cycles, which was 7 years. Ours is every other year until next year, when we go every year. So the big drop off is when all of those alternate pathways went away. And now the only way to get into the board exam is through completing and passing an ACGME accredited fellowship program in sleep medicine. And this shows you, well, to get into those fellowship programs, we participate in the National Resident Matching Program, the NRMP, and sleep is an all-in specialty, meaning we all have agreed that the only way to do it is through the match. And you can see increase in our programs where we had 20 or 30 before, we're now up to 95 fellowship programs, and the number of fellows that come out each year is about 200. So we continue to see growth in our field. Interestingly, this big jump last year was in mid-pandemic. And this is just from my talking to people, there were a good number of people who kind of got burned out from what they had to do acutely during the pandemic and saw sleep as a potential area for a little bit more satisfaction and came over. So just to kind of summarize, this is the different paths that we took. First was the development of a new and independent area of interest, sleep and sleep disorders, then establish standards for the field, clinical standards for the field, worked to get more people in, provided a forums for them to exchange information and organize activities, then make a point of establishing standards for educating clinicians through fellowship programs, and a way for them to demonstrate their clinical competence through board examination. That's been our path. So let me stop here and see if you folks have any questions.
Where do we want to start? I've got a list of questions from someone who could not attend, who's in Tuscany right now, but what is the per fellow cost for sleep medicine training on average for each site?
By cost, do you mean how much do we pay the fellows?
I guess I would ask for anything you could provide. That's all the information I had in the question.
Fellows are paid according to the standard PGY scale. Someone comes from a neurology residency, they're paid at usually a PGY 4 or 5 level, depending on the number of years. Whereas someone from from a different specialty like pulmonary and critical care comes in at a PGY 7 or 8. And then there are all the administrative and faculty costs to pay for a program director, anything. I'm afraid I could pull up a budget for you, but I'm afraid I don't have it on my fingertips. But costs that usually go into it are, you have to have a program director who's supposed to have 20% protected time for that. There's usually an administrator who helps you with the program. There are, what are the other costs involved? You have to pay for things for the fellows who come in, like malpractice, things that you would take for any trainee that's involved.
Thank you. And are these mostly affiliated with hospital systems or medical schools? These programs?
They mostly are, because that tends to be places that are used to doing academic training, but they don't have to be. An independent sleep center could meet the standards, but there are criteria for the ACGME to come out and do it, including what the facility has to do, what the clinical exposure is. They typically are affiliated in some way with a medical school, so that you have the academic standing. So it's unusual not to be affiliated with an academic institution.
Thanks. And you talked a little bit about the director of the program and the administrator. How many total staff do you think the average program has?
The ACGME requires that there be what are called key clinical faculty associated with the program, and it depends on the size, the number of fellows. So typically there's a program director and 2 to 3 other clinical faculty, so that these are the people who are involved in the training. As the program gets bigger, then you're supposed to have more people to help with the training. But those are the primary personnel involved.
Other questions?
Thanks for the talk. That was really informative. My question is, one of the things that we're kind of dealing with is, obviously we have a number of practitioners from a number of different backgrounds that we want to be inclusive of and not exclude. How were the discussions about grandfathering those people in versus the experience pathway or previous certification pathways? How did you decide on a time limit, and was that an impediment at all with ABMS to grandfather those people in?
So in our original board certification, the sort of rogue board we always had an experiential pathway. That was how the field started, because there weren't formal fellowships. So there was you had to have spent X number of months with a board certified sleep physician. You had to have read a certain number of sleep studies of different types. You had to say that you had taken care of X number of patients with different disorders. And those were the qualifications to meet the experiential requirement to get to the board. When we transitioned over to ABMS, they wanted to phase that out because that is not how they do it. They do it based on fellowship program, but they gave us, I don't recall if that's a standard number. I think the transition from an old board to a new one is relatively standard for them. They do that in most cases where something like that already exists. And since we already had the existing board and we already had the existing fellowships and pathway, they kind of set how long they would allow us to do that.
So if you passed the road board, as you call it, which we have a similar board, you were automatically eligible to sit for the ABMS board if you were previously certified by the other board?
Correct.
Thank you.
Thank you for the presentation. One of the questions that came up earlier today for us was the cost of administering the board. And it seems that for us, with the American Board of Surgery being as an example, they have some hesitations for the administrative cost of the whole program. Do you have any insight in terms of how much at the national ABMS level the conjoint board costs?
That's information I actually could find out, and I'm happy to get that information to Dean at a later date. I do know that the fewer people you have, they tend to charge you more because they recoup less from the people who are taking it, right? They charge a fee to everybody who takes a board. And so if you're a smaller group, they want to make sure that they make their administrative costs. So the fee to each of the people taking it is higher, and the fee to the organization helping sponsors is higher. But I don't have that number on the top of my head. But I could help get that to Dean.
Dovetailing off of that, we were told with the conjoint board that societies could also be the sponsor in addition to the boards, the multiple primary boards. Does sleep medicine have any societies that are sponsors for the board?
I'm sorry, I'm afraid I'm not hearing that question.
So for the conjoint board, we were informed that not only primary boards could be a sponsor for the conjoint board, but also societies. Does sleep medicine have any societies that are active sponsors in the conjoint board?
We are not actively on the board. However, all of the societies tend to come to us to recommend people, all of the people within those groups who are serving on the board are people who are sleep medicine certified. So they're all people who are part of our organization. So we've been involved in nominating people to the board along with the different, it is the different specialties that put people on the board. So we're nominating them. The AASM per se is not on the board, but we're allowed to nominate people to be on the board. They're supposed to act independently of the societies.
Yes, thank you very much. I have a question. Have they, have we kind of educated you to understand the state that we're in at this moment in terms of trying to get, working with getting board certification? Mark or anybody, have you already?
Yeah, we've shared briefly.
So in analyzing where we stand, where do you think this, process is the weakness that we may have that we should work on the most? If you have an idea, if not, that's okay too.
I'm afraid I don't know where you are in this process, but if you can demonstrate that you have our experience was that it was having the training programs and getting recognition for those forced the board to then say we need to do a board. That was how it worked for us. So if you're at the point that you have training accredited training programs that you can demonstrate a curriculum that's separate from other fields, you have people who are in them, and now you need to, and you're showing their competence in it through some form of examination, that's the time to go and get the attempt at formal recognition.
Larry, in follow-up to that, because what was intriguing is the fellowship programs led ACGME to kind of take the lead, ABMS followed. And I believe you were around 39 programs already in existence when that occurred. On the diplomate side of your road board, right, just like our road board, what number was that at that point? How many ABSM diplomates did you have at the time?
Now, let me go back to our graph. And look, we were probably in the, I'd say we were at a couple thousand at that point.
Okay, so yeah, well, when we look at our status today, we're at, right around 900 diplomats of our road board, and a very small number of fellowships at this point. So that kind of gives you the status. Everything else you shared, the pathway, disease classification, all of those things along your road path, I think we're in a pretty good position. Other questions? Well, thank you. We appreciate you taking some time out on a Saturday afternoon.
Good luck with your path.
All right. Thank you very much. And we're going to have break time. So take about 30 minutes and then we'll get started with the last part of our session.